Hey there, welcome to my channel. Today I will discuss diuretic medication pharmacology. Alright, let's talk about it. Diuretics, commonly known as water pills. Diuretics do nothing more than aid in the body's excretion of water. We must first review the basic physiology of the nephron, before we can start understanding how diuretics work. The nephron is the structural and functional unit of the kidneys. It consists of 5 different parts, each with a unique function. First, there is Bowman's capsule, which surrounds the glomerulus, a network of capillaries. Here, blood enters the afferent arteriole, where components of the blood are filtered out of the capillaries into the capsule. Filtered blood is then carried away from the glomerulus by the efferent arteriole. Next, there is the glomerular filtrate, which flows through the proximal convoluted tubule. In this region, nearly all of the water, amino acids, glucose, and approximately 90% of the bicarbonate, as well as approximately 65% of the electrolytes like sodium and potassium, along with water, are reabsorbed. As an aside, keep in mind that water and chloride ions prefer to follow sodium ions wherever they go. The descending and ascending loop of Henle, which enters the kidney's medulla, is the next major region the filtrate passes through. The walls of the descending limb are permeable to water but impermeable to sodium, so as the filtrate moves down, water leaves but sodium tends to stay, making the filtrate more concentrated. On the other hand, the opposite occurs in the ascending limb, especially in the thick limb, which is permeable to sodium but impermeable to water. As the filtrate travels up, approximately 25% of the sodium is reabsorbed passively as well as through active reabsorption mediated by the sodium-potassium 2-chloride cotransporter. After passing through the distal convoluted tubule, where the filtrate is comparatively impermeable to water, 5 to 10% of the sodium chloride is reabsorbed, primarily by the sodium chloride cotransporter. At this point, the filtrate is further diluted. After passing through the late distal tubule and collecting duct, the filtrate eventually reaches the principal cells and intercalated cells. Here, 2 hormones regulate the functions of the principal cells: aldosterone, which increases potassium secretion and sodium reabsorption, and antidiuretic hormone, which increases water permeability and, consequently, increases water reabsorption. On the other hand, aldosterone regulates the intercalated cells, but their primary purpose is to secrete hydrogen ions and reabsorb potassium. Diuretics simply increase the volume of urine produced by working on different regions of the nephron. Diuretics are currently classified into 5 main types according to their mechanisms of action: carbonic anhydrase inhibitors, osmotic diuretics, loop diuretics, thiazides diuretics, and potassium-sparing diuretics. Let's now look into each class. Let's start by discussing carbonic anhydrase inhibitors, which primarily cause their diuretic effect by decreasing the reabsorption of bicarbonate in the proximal convoluted tubule. Currently, acetazolamide is one of the most widely used medications in this class. However, because of its relatively limited diuretic effect, acetazolamide is frequently used for its other pharmacologic actions. To better understand how these agents work, let's focus on the proximal tubule epithelial cell. So, to the left of the epithelial cell, we have the lumen, where urine is being formed, and to the right we have the interstitium, which contains blood vessels. Here, bicarbonate reabsorption is triggered by the action of a sodium-hydrogen ion exchanger, which allows sodium to enter the cell in exchange for hydrogen ions. Next, reabsorbed sodium is pumped out of the cell by sodium-potassium ATPase, where the hydrogen ion that is secreted combines with the luminal bicarbonate ion to form carbonic acid. Then, an enzyme called carbonic anhydrase rapidly dehydrates carbonic acid to carbon dioxide and water. Carbon dioxide then enters the epithelial cell by simple diffusion and gets rehydrated back to carbonic acid by intracellular carbonic anhydrase. Finally, intracellular carbonic acid dissociates to form hydrogen ions, which can be transported to the lumen by a sodium-hydrogen exchanger, and bicarbonate ions, which are transported out of the cell. When carbonic anhydrase inhibitors are introduced, they inhibit the carbonic anhydrase enzyme, causing bicarbonate to be retained in the lumen because bicarbonate reabsorption utilizes the sodium-hydrogen exchanger. This causes a significant reduction in proximal tubule sodium reabsorption, which in turn causes mild diuresis. Since most of the sodium that isn't reabsorbed in the proximal tubule is still reabsorbed by the distal part of the nephron, the diuretic effect is only mild. However, this late reabsorption also increases potassium secretion, which is one of the class's side effects. Another side effect of carbonic anhydrase inhibitors is renal stone formation. Additionally, because bicarbonate plays a significant role in the circulation's acid-base buffering system, its wasting causes an increase in plasma acidity known as metabolic acidosis. The drug should be avoided in patients with hepatic cirrhosis because it could lead to a decreased excretion of ammonium ions. Let's move on to osmotic diuretics. These diuretics work by directly interfering with osmosis. Mannitol and urea are two examples of osmotic diuretics. As you may remember from your basic biology class, water has a tendency to move across membranes from lower osmolarity, or the dilute side, to a higher osmolarity, or the concentrated side. These osmotic agents are filtered from the glomerulus because they are highly water-soluble, or hydrophilic, and because of their large molecular size, they undergo very limited reabsorption. This results in increased osmolarity of the tubular fluid, which reduces water reabsorption. Because they increase the excretion of water rather than sodium, they are not very effective in treating edema caused by sodium retention. Osmotic diuretics are primarily used to lower intracranial pressure, promote the excretion of toxic substances through the urine, and increase urine production in patients suffering from acute kidney failure. As for their side effects, using them can cause significant fluid changes, such as volume overload or dehydration, which can result in electrolyte imbalances. Let's move on to the most significant class, which is loop diuretics. As their name indicates, loop diuretics act in the ascending limb of the loop of Henle, specifically blocking the sodium-potassium 2-chloride cotransporter. Medications in this class include bumetanide, furosemide, torsemide, ethacrynic acid. Out of all the diuretics, these agents have the greatest diuretic effect because up to 25% of sodium is reabsorbed in the ascending limb, at which point other parts of the nephron can no longer compensate for increased levels of tubular sodium. Now let's look closely into the cell that lines the thick ascending limb to see what actually happens there. Some of the filtered sodium, potassium, and chloride are reabsorbed by the sodium-potassium 2-chloride cotransporter, which, among other things, causes potassium accumulation within this cell. However, potassium also has a tendency to leak out through potassium channels back into the lumen, contributing to a more positive charge there. This positivity in the lumen creates an electrical driving force for the pericellular reabsorption of cations, like calcium and magnesium, so when a loop diuretic occurs and blocks the sodium-potassium 2-chloride cotransporter, we lose not only water and sodium but also potassium, calcium, and magnesium. Now remember that the late distal tubule is where potassium loss primarily occurs because sodium-rich fluid improves sodium-potassium exchange. When it comes to side effects, loop diuretics may cause acute hypovolemia, which is an excessive and rapid drop in blood volume. This can result in hypotension shock and even cardiac arrhythmias. Due to the fact that loop diuretics suppress the sodium-potassium 2-chloride cotransporter, which is also present in the inner ear, their use has also been linked to ototoxicity or damage to the hearing. Also, uric acid transport is mostly competed with by ethacrynic acid and furosemide, which block uric acid from being secreted and can eventually cause hyperuricemia, which exacerbates gout symptoms. Lastly, the loss of potassium from cells in exchange for hydrogen ion leads to hypokalemic alkalosis. Use of potassium-sparing diuretics or supplementation with potassium can prevent the development of hypokalemia. Let us now discuss thiazide diuretics. Thiazides are probably the diuretics that are prescribed the most frequently. Drugs in this class include chlorothiazide and hydrochlorothiazide, which are structurally similar sulfonamide derivatives. We also have chlorthalidone, indapamide, and metolazone, which are referred to as thiazide-like drugs because they lack a true thiazide ring but share the same mechanism of action. They primarily act in the early distal tubule, where they increase the excretion of sodium chloride by inhibiting the sodium chloride cotransporter. However, because over 90% of sodium is reabsorbed before it reaches the distal tubule, thiazides generally produce relatively weak diuresis. On the other hand, thiazides can cause vasodilation, which lowers peripheral vascular resistance through a mechanism that is, unfortunately, still unclear. Let us now focus on the epithelial cell of the early distal tubules to examine what exactly occurs there. Here, sodium and chloride enter the cell through the sodium chloride cotransporter. Once inside the cell, sodium is transported to the blood through the sodium-potassium ATPase, while chloride diffuses out via the chloride channel. Thiazide diuretics then inhibit this sodium chloride cotransporter, which reduces the reabsorption of sodium chloride. Ultimately, since water follows salt, we get increase in urine output. In terms of side effects, thiazides can cause hypokalemia due to increased sodium delivery to the distal parts of the tubule. Additionally, by interfering with uric acid transport, thiazides can cause hyperuricemia, which may worsen gout. Loop diuretics can cause hypocalcemia due to increased calcium excretion. Conversely, thiazides can have the reverse effect, resulting in hypercalcemia. There are two suggested reasons for this. The first occurs in the proximal tubule, where thiazide-induced volume depletion causes an increase in sodium reabsorption as a compensatory measure. This electrical gradient then causes passive calcium reabsorption. The second mechanism is thiazides block the sodium chloride cotransporter, which lowers the concentration of sodium inside the cell. This, in turn, causes the sodium-calcium exchanger on the basolateral side of the distal tubule to take in more sodium in exchange for calcium, which is then excreted into the bloodstream. Lastly, thiazides may decrease glucose regulation, resulting in hyperglycemia. Several mechanisms are believed to be responsible for these consequences, such as elevated hepatic glucose production and impaired insulin sensitivity and secretion. Before we finish this lecture, I wanted to quickly go over the last class of diuretics, which are called potassium-sparing diuretics. These diuretics mainly act in the collecting tubule, where they block the excretion of potassium and the reabsorption of sodium. Drugs in this class include spironolactone, eplerenone, amiloride and triantarene. Even though being relatively weak diuretics, they are frequently used in conjunction with diuretics from other classes to enhance their effects. Now, let's pay attention to the principal cell of the collecting tubule to understand what exactly happens there. Under normal conditions, the principal cell has separate channels for potassium and sodium as well as sodium-potassium ATPase on the basolateral side. Here, sodium enters the cell through the sodium channel, and then is transported sodium-potassium ATPase into the bloodstream in exchange for potassium. As you can see, this illustration should also help you understand how loop diuretics and thiazides lead to potassium loss. Specifically, increased sodium load from loop diuretics and thiazides enhances sodium reabsorption, which makes lumen more negative. This creates a driving force for increased potassium secretion, which in turn lowers potassium levels in the bloodstream, resulting in hypokalemia. This is because the lumen negative electrical potential is generated here because this sodium entry predominates, and chloride is driven into the bloodstream through a paracellular pathway. Returning to the potassium-sparing diuretics, these drugs can be further divided into two groups according to their unique mechanisms of action. The first group functions by antagonizing aldosterone. Aldosterone is a hormone that enters cells, binds to an intracellular receptor, and stimulates the transcription of genes that encode sodium channels and sodium-potassium ATPases, increasing their expression. In other words, aldosterone increases the reabsorption of sodium and water as well as potassium secretion. Because aldosterone antagonists compete with aldosterone to bind to this intracellular receptor, the result is reduced synthesis of proteins that activate sodium channels and a decreased number of sodium-potassium ATPases, which ultimately leads to potassium retention. Examples of drugs in this category include spironolactone and eplerenone. On the other hand, the second group now acts by blocking the sodium channel, which lowers potassium exchange and causes potassium to be retained in the drug. Examples of this group include amiloride and triantarene. As you may have predicted, hyperkalemia is the most common adverse effect of diuretics, particularly when taken with other medications that can raise potassium levels. Finally, spironolactone can stimulate the receptors for testosterone and progesterone, causing consequences like irregular menstruation in women and gynecomastia in men, because of its chemical structure, which is similar to our natural steroid hormones. Let's conclude by stating that diuretics function by working on several nephron components to eliminate water from the body. Carbonic anhydrase inhibitors, osmotic diuretics, loop diuretics, thiazide diuretics, and potassium-sparing diuretics are the 5 main groups. I've highlighted the key information regarding diuretics for you. Try not to forget these. Finally, I just wanted to say thank you for watching. I hope you enjoyed this video, and as always, check back for more. Take care, and good luck with studying.